My name is John Guiney. I'm the director of the Jesuit Centre of Faith and Justice here in Dublin. Our centre is one of a network of social centres around the globe where Jesuits are working, where we do social analysis, social research, publications and advocacy on social issues that touch the lives of the people we work with and we live with, especially the most marginalised in our society. The Centre is very pleased to have this opportunity of working jointly with TASC and the Adelaide Hospital Society to organise and host this conference. The focus of our work of the Centre in Dublin is the promotion of social justice in Ireland today. We believe that an essential feature of a socially just society has to be the availability of a health service that is based on need, not ability to pay, and which is inspired by an ethos of care as well as professional expertise. We in the Jesuit Centre have shared the concern expressed by many groups over the years about the two-tier nature of the Irish health system and its consequences in terms of inequalities in speed of access to services and quality of care provided. Like TASC and the Adelaide Hospital Society, we hope that this event of today will not just be a means of considering the proposals of the coalition government for health service reform and assessing progress to date, but will serve indeed to provide an added impetus and energy to the urgent, though difficult task of implementing these proposals. It's my pleasant duty to introduce the final speaker at today's conference. Professor Kieke Okma is currently Associate Professor at the Wagner School of Public Service, New York University, and Visiting Professor at both Cornell University and the Catholic University of Louvain in Belgium. She worked on health policy issues with Dutch government agencies and international organisations for over 25 years. She has lectured widely and published on a range of issues relating to health policy, health politics, and international comparison in health policies. Let us welcome Professor Kieke Okma.
And I'm very sorry that you're still here, sitting all day. I feel very honored for the first time in my life that as a lapsed Protestant I'm being welcomed by a revert Jesuit. But one of the things I do remember of my early childhood, when we went to church on Sundays, we would never have 12 reverends in a row with who would give 12 sermons, would you? There's much more variety. Singing, it's standing, and I feel like sitting all day, it's a little bit of a long day. So I've tried to cut as far as I could. But let me first start with another light note about Adlai Stevenson. You may remember him as a famous American politician. He was a great orator. He was a very good speaker. And once he gave this very good speech. After the speech, this elderly lady came up to me and said, "Professor Stevenson, that was a wonderful, superfluous speech." And he thought, well, perhaps irony is the best answer to that. He said, "Well, lady, given your enthusiasm, maybe I should publish that posthumously." "Oh," she said, "wonderful, the sooner the better." Anyway, what is relevant for today, it's about understanding and misunderstanding, about language and how we look at language. Now, we've heard already a couple of people today talk about Holland, but they didn't really tell us what Holland has done or what it is. And I have this great pleasure to be asked to try and tell you what exactly happened in Holland with this so-called Dutch model. Let me first throw in trivial thought as a political scientist. When you hear that type of discussion about consumer choice, the Dutch model, the first thing is policy as framed in formal policy documents is hardly ever the same as policy actually implemented, let alone as the outcome of policies. So that's one. Secondly, government policy making is hardly ever just a matter of governments. Policy making is shaped by ideas and institutions and interest in society. So governments always push towards slightly different directions. And finally, importantly, politicians, and not only politicians, I hasten to add, use labels and terms that very often are not very clear, but sometimes outright misleading or confusing. If you have heard the term the Dutch model of consumer-driven healthcare, for example, or managed competition, does that really tell you what it did, what it does, what it's supposed to be doing? Now, I'll try to give you a little bit more of a detailed picture of Holland, perhaps more detailed than you really would like to hear this time of the day, but at least in future discussions you'll be able to talk with a little bit more authority about what happened in our little country across the sea. First, briefly, the underlying assumptions of that model of managed competition as we have implemented in Holland. At least we have said we have implemented in Holland. There are four assumptions. The first is citizens, insured, are keen and willing to shop around for the best health insurance plan, what's best for them. Second, health insurers will be keen and willing to compete and to go to providers of healthcare to contract with the best and cheapest and nicest care on behalf of their insured. Third, providers would be eager and willing to compete to offer the best and cheapest and most patient-friendly care in order to get those contracts. And four, governments will keep their hands off. So that's basically the model. Now, what happened after Holland actually implemented that model? And what's interesting, Switzerland did the same 10 years earlier, and that's very comparable. Let me focus on Holland mostly. All legal residents in both of the countries have to take out health insurance. If they don't all do that, we have sort of leftover bit of the population who doesn't take out insurance, and it's very embarrassing. Moreover, we have people who don't really pay their bills. That's embarrassing for government, but in principle, everyone in Holland has to take out health insurance. Second, the coverage of that basic health insurance is almost identical to the former social insurance. It's a wide range of hospital care, outpatient care, prescription drugs, medical aids, you name it, it's all in there. Third, insurers cannot turn down anyone, and they cannot charge premiums according to risk. So they cannot charge elderly people higher premiums than younger ones, say. Four, the insured can opt for the so-called managed care plans that would give you a lower premium in exchange for a higher deductible in the first place, and second, for a more limited number of providers you could go to, and finally, the insurers receive subsidy based on that sort of risk equalization fund that supposedly will work in not eliminating, I think what Steve talked about this morning, it's not eliminating risk selection, but it will reduce the incentive to select risks. I'll come back to that in a moment. So the Dutch now pay their insurance out of different pockets. You always pay your healthcare out of different pockets. You know, it's your taxation or it's insurance or out of pocket. You have about 4 or 5 pockets in which we pay healthcare. So in Holland, it's the direct premium they pay to the health insurer, about 110 euros per month. It's the income-related premium. That's another part of the premium paid by as earmarked taxation, by employers paid through the tax system, and that is being reallocated to insure based on that risk equalization scheme. Third, there's out-of-pocket payment, fairly low in Holland, but there's some. Fourth, there is the private health insurance for things that are not covered, or for supplemental stuff. And fifth, Dutch pay quite a lot via general taxation, because taxes have gone up to finance for the whole thing. And those different funding, those different pockets clearly have different distributional consequences. Some are more progressive than others, or less progressive. Now, what have been the results? What have been the outcomes of what happened after we introduced those insurance mandates in 2006? The first striking feature, both in Holland and in Switzerland, was a massive increase in the cost of health insurance, cost in health expenditure. Total health expenditure went up from 8 to 12% of GDP within 6 years. That's quite. I mean, we outdid Ireland in a speed of increase in those years. You can't really blame insurance for all of that, but on the other hand, we cannot say that the new model has really greatly helped contain costs. We're now in the top 10 spenders, top 5 spenders of the world. The government expenditure went up because the complexity of the system, administration, and all sorts of subsidy into the system. And Dutch families are facing higher direct costs after delisting of services, or because of the fiscal subsidy for low-income countries didn't keep pace with the average rise of premiums, the shift of certain entitlements, delisting of entitlements from social insurance to the supplemental scheme. So for different reasons, the direct cost to families went up too. Secondly, the assumption that insurers and providers would happily engage in competitive behavior was a little bit over-optimistic, perhaps, because what both did with much more vigor was to try and secure their market positions. So what we see is that there was an enormous acceleration in the processes of mergers, in particular in the insurance industry that has been mentioned already this morning. Although there are still 48 legally independent insurers in Holland, almost all of them are part of larger financial conglomerates, and there are now 4 large conglomerates that capture 90% of the market. So there's not very much competition there, and it shows. I looked at all the plans they have, and for the basic insurance, all of them, no exception, offer premiums of between 92 and 118 euros per month. So the identical entitlements and the identical prices. So there's not very much competition there, but they've been extraordinarily creative in the supplemental insurances. And there's one insurance that really, I must say, trumps it all, offering coverage for acupuncture and alternative medicine for a mere 55 euros a month, with only an annual total cap of 500 euros. So it needs some advanced maths before you can find out whether you would sign up for that. Now, while the whole system in sort of the idea of competition is based on selective contracting, the insurers have power to discontinue contracts. They haven't done that. They don't like to do that. Actually, in a small country like Holland, we're a little bit bigger than Ireland, but not much bigger, there is really not that much real exit for parties. You are living in the same place. You have to continue living in the place, and rather than having, fighting with the physicians, fighting with hospitals, insurers are much more comfortable in just creating bigger monopoly positions, so they don't have to do that in the first place. Patients have virtually unlimited access to any healthcare system in the country. So that's a good way, and good news, as it were. As a side remark here, I think the Dutch model clearly illustrates that competition in healthcare is not really the best instrument for cost control. There is no country in the world where that has been the case, or where it has been successful. And what it has been successful all over the world is one element only, and that is the use of collective bargaining power. Countries that have systems where either the government or regions, like in Canada, the Canadian regions model, the sick funds would get together and would collectively bargain with the organizations of hospitals or organizations of doctors. You'd have collective bargaining power. And then you could sit down and say, we're going to talk about volumes and tariffs and perhaps qualities and other parts of the services. The third outcome of the Dutch model was that actually people have not been very keen in switching plans. One of the ideas, consumer-driven healthcare, consumers are going to shop around changing plans, and therefore, first year, 20% of the Dutch switched plans. So that was pretty impressive, almost 70%, pretty impressive. However, it turned out most of those were part of a collective contract offered by their employer. Second year, the percentage had dropped until 5% in years after, and in those years, 80% of the switchers were changed as part of their employer-sponsored plan. So only 1% of the population is changing based on individual choice, one of the cornerstone of the model. Moreover, predictably, the people who are switching, who are the switchers? Predictably, who is switching in Holland? You don't know anything about the Holland, but you can predict who will be switching. Young. Who else? Healthy.
Better off.
Better off. There you are. That's it. It's as simple as that. And in Switzerland, the same story, or in Chile has had the same story too. So it's a bit worrisome that the people who need healthcare most, elderly, disabled, chronic ill, are least likely to go around shopping and act as consumers who driving the system. And finally, the market did not really replace government. The other idea. Government actually, if anything, expanded its role in monitoring and all sorts of market institutions, new marketing and monitoring agencies, but also the health ministry kept firmly its position in developing information technology, the new quality systems, case-based payment systems, the models for hospital payments, other activities. I think the health and the Treasury had to hire another 600 people because they had to administer the fiscal subsidy for low-income people. It's very labor-intensive because you have to check the monthly income of every family to check the eligibility for fiscal subsidy and the level of fiscal subsidy. And that's quite a detailed job. The transformation towards this system didn't go very smoothly, we should hasten to add. The first is that famous risk equalization scheme the health economists of Rotterdam have been making a living off for the last 30 years, and a pretty good living, I should add. So they have a big stake in telling us that it's a good system, but it only needs to be elaborated a little bit more. So the system has been expanding very dramatically in the last 10 years. It has become more complicated, it has become more elaborate. It may have been better in predicting cost, not quite certain it does, but it certainly has become very expensive. And it's still far from complete. Now, if we look at the little country of Israel, with about 5 million people, they have, for the risk equalization system, they only use one criteria, namely age. And if you think about it, if you have only 4 large insurance agencies, you don't need a detailed system. So you may want to go to Israel instead of Holland if you want to go that direction. Second, we have had a very elaborate bottom-up process of developing the DRGs, the case-based payment model for hospitals. And Dutch, being a little bit sort of independent, or how to label that, decided that he wouldn't go out and copy the system of someone else. I remember 15 years ago, or 10 years ago in the health department, I said, you guys, why don't we just go to Australia? They have DRGs, they're nice. I mean, the Aussies, they'll be willing to give us their system for free. And why don't we just copy their system? We can start next week. No, we have to do it our way. So the Dutch decided to develop a very complicated homegrown system and asked every single little hospital to develop their own DRGs. In the end, we ended up with 30,000 different tariffs. Don't laugh at that. It was very detailed, and the idea was it would allow for a great deal of transparencies. But so we ended up with 30,000 DRGs, it was not just diagnosis group plus activity-based tariffs, only covering about 20% of hospital costs. So it was a little bit of an embarrassment. The government then decided to reduce that number, to try to simplify the system, and announced that again and again, and doesn't really know how to do that. But it's not quite willing yet to just throw it overboard. I mean, after all, we've been investing over 200, I think about 300 million euros into this system, and start all over and go to Australia or America, to CMS. They only have 900 DRGs. So if you want DRGs, don't go to Holland. There's one point I would like to raise that's very different between Ireland and Holland and to Switzerland to a bit of a lesser degree. And that's the fact that Holland has had the system of social health insurance in place for about 100 years. And the carriers, the administrators of that social health insurance, the sick funds, have been in place much longer. Actually, they have historical roots in the Middle Ages, but it's a different point. But they have had decades and decades of experience with bargaining, negotiating with hospitals and doctors. So they've done that job for many, many years. Non-governmental organizations feeling themselves firmly anchored in the public domain, but as legally independent agencies taking on the public role of administering the social health insurance. And Ireland doesn't have that tradition. You don't create that overnight. So that's an important point I'd like to add. Finally, most of the elements we're talking about as part of that so-called managed competition model do not really require a shift towards a competing health insurance model at all. For example, working on case-based payments is something you can do regardless. I mean, Australia has case-based payments based within their public health, funding model. So it may be useful if you want to have a quasi-provider purchaser split. It doesn't require any further shift towards health insurance. Second, information technology may be useful to invest in, as long as you don't embrace the ever-evading dream of electronic medical records. I'm firmly convinced that we will never get there, so you might as well give it up or slow down your ambitions. And independent management of hospitals, again, same story. A hospital trust may be very good for all of us. There's nothing wrong with that. So all of those elements, I'm not against that. Now, and final one, consumer choice. We're talking about consumer choice. Well, here I must say we have a remarkable absence of serious polling whether grandma actually wants to shop around for health insurance. It's no kind. Holland's never done of that. Of course, we haven't. But maybe you might consider that. And so my only really practical suggestion is, let's ask grandma. Does she want to choose? Does she want to have a choice of plan, or does she want to have a choice of provider? So that would be, my agenda for you would be very small. Let's ask the consumer, and particularly let's ask grandma. That's all I would like to suggest to you. Thank you. Chris Curl,